Welcome everybody to our Dine and Learn event tonight. My name is Dr. Elaine Howe. I am a family physician who works here on the North Shore. I'm also
cancers per 10,000 women per year on hormone therapy. That's one of the reasons
part of the Lionsgate Maternity Clinic, but I will not. If I could ask everybody to please mute their microphones if they're not speaking, that would be great. I will be moderating tonight's event. And I just want to start off with a land acknowledgement before we begin, just acknowledging the fact that we are very grateful to be able to live, work, and most of us probably being here in attendance on the unceded and traditional ancestral lands of the Coast Salish, including the Musqueam, Squamish, and Tsleil-Waututh peoples. So our topic tonight, as all of you hopefully know, is Dine and Learn with the Lionsgate Maternity Clinic to identify some gaps in maternity care, or not gaps, but CME for maternity care as well as newborn care on the North Shore. If you could please hold your questions until after our 30-minute times two, so a 1 hour long presentation, that would be greatly appreciated. We do have half an hour allotted at the end for questions, which you can enter in the chat box or also use the raise hand function. Now, the very important thing that we all need to do also is to complete the evaluation at the end of tonight in order to receive CME credits. You'll also be eligible for an Uber Eats gift certificate as well. If you just make sure that you've got your name at the bottom of your, or you've labeled your name in the Zoom screen, and then complete the evaluation in order to have access to that. I'd like to thank our division staff, Steve, for helping with all of coordination tonight. And then also wanted to thank, so we've got Dr. Mary Glenn, who are two of the Lionsgate Maternity Clinic physicians. If they would like to further introduce themselves, I'll allow time here. Otherwise, we should be able to just get right into the meat of the talk.
Yeah, I can go ahead. First, I'm Dr. Mary Glenn. I've been with the maternity clinic since about 2017. And Dr. Mask-Newmeyer, do you want to do a quick hello?
I'm Tegan Maslick-Newmeyer. I've been with the Lionsgate Maternity Clinic since 2019. And before that was in Edmonton.
So we'll go ahead and get started here. Neither of us have any disclosures. We've already acknowledged the land. Thank you, Elaine. So today we're going to...
No.
Okay. Today we're just going to talk a little bit about the options for prenatal care on the North Shore, about us at the Lionsgate Maternity Clinic, kind of review some of the key features of early prenatal care with the hopes that that may increase confidence for family doctors in providing early pregnancy care, and then some of the common things we see in the postpartum period as well, and then of course questions. And just a note, the term women will be used to encompass sort of all individuals who possess a uterus, so that could include transgender men and non-binary individuals who may have uterus. So a little bit about prenatal care on the North Shore. Last year, we delivered about 1,300 babies at Lionsgate. That's everyone at Lionsgate. And we service the North Shore, West Vancouver, Sea to Sky corridor, which includes Bowen and all the way up to Pemberton as well. That number hasn't actually changed drastically over the last several years. However, we are experiencing some current capacity challenges just due to the reduced number of care providers on the North Shore. So there were previously a couple of different groups of midwives and some more family physicians providing maternity care. However, those have kind of reduced in recent years. So for patients who are wanting midwifery care, they have a limited capacity for how many patients they can take each month. And in the last year, the Lionsgate Maternity Clinic has had to cap referrals at times just because the workload is not manageable for us. And that cap we have set at about 65 per month. We don't have that every month. And then the OBs have now also had to say that they're not able to provide any low-risk maternity care just because it's adding to their wait times for gynae and other issues. And so, when you do the math, it does mean that there are there are months in which we can't accommodate all the patients we would like to. In terms of current options for prenatal care on the North Shore, there's the Lions Gate Maternity Clinic, which everyone's aware of. In terms of midwifery options, the only midwife group right now are the Canopy Midwives, and they do pregnancy, intrapartum, and postpartum care. And then a really nice option for patients who perhaps wanted to be with a midwife or with an OB, or just want a little extra support in the postpartum care period is to go, with either one of the other options, and then just have postpartum only care. And that's provided by Canopy, or Vera Berard is another one of the midwives who provides that postpartum care only. So that's a good option for some people. There are a couple of GPs left who are doing maternity, Dr. Chow and Dr. Half, who see their own patients and a limited number of referrals. And then our obstetricians are now only able to see high-risk patients. So just a brief intro to some of the other options. So Canopy Midwives, they provide pregnancy care from early pregnancy to 6 weeks postpartum. They do offer home births, and they do home visits postpartum. They do have a fairly similar scope to the maternity clinic in the sense that they're kind of like low risk providers. They are able to order ultrasounds, labs, refer to specialists. So we've heard from them that often they have patients who were told by their family physicians that they weren't able to go to midwifery because of medical condition, but often they are able to. So that's something of note. However, they have quite a limited capacity, about 24 to 26 patients per month. So if you have a patient who's wanting to go with Canopy, you can refer them yourself, and they would request to refer as early as possible. And the patient must complete the intake form on the Canopy website, and Canopy won't really contact them until that intake form is done. So that's something just to make sure your patients are aware of. They can just go to their website and do that on their own. In terms of our obstetricians, as I mentioned, they only do high-risk pregnancies. So those would be twins, patients with pre-existing hypertension, pre-existing diabetes, age greater than 45, or previous high-risk complication, which is a little bit generic. So if you're unsure, you can always reach out to the Lions Gate Maternity Clinic. Either you can send a referral, and if it's clear that they're not appropriate for us, we can redirect, or you can always just call and speak with one of us, and we'd be happy to let you know if that patient is appropriate for us or more appropriate for an OB. And then finally, us here at the Lions Gate Maternity Clinic, we're a group of female family physicians. Numbers a little bit of a moving target because we have some new locums working with us, and we provide care from about 13 weeks to 6 weeks postpartum. We work as a group, so patients have the chance to kind of meet all of us throughout the course of their pregnancy, and then their labor will be managed by whoever is on call on that given day. In 2024, we did 614 deliveries, which was up from about 551 in 2023 and 480 in 2020. So as you can see, our numbers have really increased quite dramatically, which has led to some of our capacity challenges. How to access us, we do have a new referral form on our website, Pathways, and I believe it was sent out to GP offices. I've had some people ask me, is it required? No, it's not required. We'll take referrals sort of in any way. However, it was designed to be like a helpful resource for people who don't do a lot of early pregnancy care. So it does include which lab work we would recommend doing, as well as if your patient would qualify for aspirin based on the new aspirin guidelines. So that's why it's a little bit lengthy. So if you're not sure, take a look at it. A lot of patients are qualifying for aspirin these days, and we'll talk a bit more about that later. And just of note, and this is both for us and for Canopy, we will only see patients who live in the catchment area and those with active MSP coverage. So a little bit more about us. We'll see patients for their first appointment around 13 weeks after their first ultrasound has been done, just to confirm that the pregnancy is viable, not twins or anything like that. We're going to chat a little bit more about this shortly, but there have been some changes in terms of the timing of when dating ultrasounds are done. They're being done a little bit later now. So the visit with us may be a little bit later than it previously was. And so it's really important to discuss prenatal screening with your patients if you can. And then we'll follow patients through from pregnancy, delivery, and the early postpartum period. And due to that increased demand, if babies are doing well and they have a GP, we will plan to discharge them as early as 2 weeks or 4 weeks if we need to follow them a little bit longer. We'll see moms for a final 6-week check if they've had a vaginal delivery or an assisted vaginal delivery. We can talk about contraception. We can see them for their IUDs and implants if that's their desire. And if they've had a C-section delivery with us, they'll end up seeing the OB for the 6-week check. And the final thing is just to note that there may be some changes coming to this in the next 6 to 12 months. We've just started having some conversations and trying to streamline to like a centralized intake with the hope that that will make it easier as well as to improve capacity. So stay tuned.
All right, so I'll be doing this section on early prenatal care. So the first steps, I'll go through each of these in more detail, but we'll talk about dating ultrasound, lab work, genetic screening, preeclampsia risk assessment, and aspirin, and then referral to maternity care provider. Mary just touched on that. I also wanted to make a note that on Pathways, there is a nice little algorithm called the Early Pregnancy Enhanced Care Pathway, which has lots of information about all these tests to order and links for the provider and good resources for patients as well. So the dating ultrasound, as of May 1st this year, as per new VCH guidelines, North Shore Medical Imaging will only do dating ultrasounds between 11 weeks and 0 days and 13 days and 6 weeks. So this is in alignment with an updated Perinatal Services BC guideline. The intention behind that the intention behind delaying the dating ultrasound is that it offers an opportunity for basic anatomical assessment and early detection of severe anatomical anomalies without compromising dating accuracy or adding to the total number of ultrasounds a patient will have. So what this means for the community GPs is that your patients you may be seeing your patients for a bit longer prior to them being followed by a maternity care provider. And the discussion with your patient about genetic testing will need to occur usually before they see us. Just a little plug here for this pilot project going on at BC Women's Hospital. Any patient with a BMI over 35 can be referred to have an extra ultrasound done between 13 and 15 weeks, and they'll also have their anatomical scan there as well. And this is because knowing that the patients with a BMI over 35, they have an increased risk of fetal anomalies and a risk of not catching these at the 20-week ultrasound. So first prenatal lab work is likely familiar to most of you, but we'll review this. So CBC and ferritin is necessary, TSH in everyone. Urine culture and sensitivity. Life labs often will not run this unless you specifically write pregnant, rule out asymptomatic bacteriuria. So we see a lot of this not resulted when the patient gets to our clinic. Blood type and antibody screen, chlamydia and gonorrhea, either urine or vaginal swab, and then infectious serology, so HIV, hepatitis B, hepatitis C in everyone, syphilis, rubella, and varicella if you're not sure their immunity status. Thalassemia screening in at-risk patients with hemoglobin electrophoresis. I'll talk a little more about that on another slide. B12 in patients who are vegan. Consideration for hemoglobin A1C should be taken into account for high-risk patients to identify patients who maybe were missed being diagnosed with type 2 diabetes. So this any risk factor for type 2 diabetes, but pre-diabetes, previous GDM, BMI over 31, age over 40, or strong family history. Pap smear is recommended to be updated if it is due, and it must be a cytology rather than a self-HPV swab to minimize bleeding of the cervix. Not indicated for routine prenatal lab work is lipids, electrolytes, creatinine, EGFR, and LFTs. There is a requisition on pathways under forms called laboratory requisition for maternity care. And it has all these tests. You can just click the box and they are organized by gestational age. And it includes the later pregnancy too. That's a picture of where to find it on pathways, and it's a little bit small, but you can see what the requisition would look like there. So thalassemia and hemoglobinopathy screening, this is ethnicity-based population screening of some autosomal recessive conditions. Babies may have a combination of hemoglobin variants, and some combinations may result in fetal anemia, which requires treatment and follow-up. So the higher risk ethnicities are listed here. I think it's easier to remember who not to screen, the lower risk ethnicity. So Japanese, Koreans, Caucasians of Northern European ancestry, and First Nations in Canada. And if the patient just doesn't know, I think it's reasonable to screen. If there is a positive result, the partner of the pregnant person needs to be screened as well. I would order CBC, ferritin, hemoglobin electrophoresis. And if both partners are found to be carriers, the patient should be referred to medical genetics at BC Women's for counseling. They may be offered amnio or CVS. So a quick note on hypothyroidism, pre-existing hypothyroidism. It's important to know about. Inadequately treated hypothyroidism can lead to adverse outcomes for pregnant women and the fetus, and if severe, can lead to impaired brain development in baby. So levothyroxine requirements increase during pregnancy. So women taking levothyroxine should increase their dose by 20 to 30% as soon as they find out they're pregnant. A simple trick is to increase by 2 pills per week. And the TSH will be checked every 4 weeks during the first half of pregnancy or until the dose is stable, with the goal of targeting 2.5 or less. Okay, preeclampsia risk assessment and prevention with ASA. So just a reminder, what preeclampsia is: a multi-system disorder in pregnancy characterized by new onset hypertension after 20 weeks, and it's associated with end organ damage with or without proteinuria. It's fairly common. It's seen in upwards of 8% of pregnancies. It can lead to significant fetal and maternal morbidity, and we know that aspirin can help prevent or delay the onset of severe preeclampsia. So it is important to recognize risk factors in every patient who presents with a new pregnancy. This is the most current table that we are using in BC. And some of the more common risk factors that you'll see include pre-existing or chronic hypertension, type 1 and type 2 diabetics, and then moderate risk factors, if there's 2 or more of these: nulliparity, maternal age over 35, BMI over 30, in vitro conception. Those are some of the more common risk factors you'll see. And these patients, if they have so many risk factors, they will need to be started on aspirin. Ideal timing is between 11 and 16 weeks. The dose is still kind of up for debate whether higher doses are more beneficial, but for now, 81 milligrams a day seems to be reasonable. And then we also recommend calcium of 1,000 milligrams a day. And then we would stop aspirin at 36 weeks. And these are the contraindications to aspirin, absolute and relative. I won't read through them. Okay, prenatal genetic screening in BC. There are these are various time-sensitive blood tests that should be offered to everyone, but are not mandatory. So some patients may choose not to screen. These screening tests are just screening. They are not diagnostic, and if positive, they will be offered further testing. The publicly funded ones were originally developed to identify the risk of having a pregnancy that has trisomy 21, 18, or open neural tube defects. The type of test recommended is based on patient preferences, maternal age, and gestational age at time of presentation. I would like to point out also the detailed anatomical scan, which is routine in every patient, is also a form of a screen for anatomical abnormalities. There's great resources online. We have a list at the end of our presentation. Good resources for provider and patient, including a decision aid brochure with some images. So I'll go in more detail on the next slide here, but the publicly funded ones, wait, just go back. Publicly funded ones, lots of acronyms. SIPS, Serum Integrated Prenatal Screening. IPS is Integrated Prenatal Screening, which is the SIPS plus a nuchal translucency ultrasound. And then the quad screen is just the SIPS part 2 for late people who present late. And then we have a NIPT, which is a non-invasive prenatal test for high-risk patients. It's funded. And then we have chorionic villus sampling and amniocentesis for people over 40. Or age of 40 or older. And then private tests, we have the NIPT again, or first trimester screen. Okay, so this is a review of the most common publicly funded tests you would order and talk to with patients. And again, the type of test is based on the patient age and gestational age at the time of the prenatal visit. So this table is available on Perinatal Services website. So it's separated by the age of the patient and then their gestational age at prenatal visit. So I find it very helpful. So the SIPS is 2 blood tests looking at different hormone markers. Part 1 has to be ordered between 9 weeks and 13 weeks and 6 days. Part 2 is between 14 weeks and 20 weeks and 6 days. The IPS, which is the SIPS, plus a nuchal translucency ultrasound. This is offered to women who are 35 or older at the time of the due date, or those with twins. And the nuchal translucency ultrasound is time sensitive. It's ideally done between 11 weeks and 13 weeks and 6 days. We recently, all GP offices should have received a notice from North Shore Medical Imaging about the change to the dating ultrasound, and a notification that they will only be doing the nuchal translucency starting at 12 weeks and 0 days. And you cannot order the NT ultrasound at Lionsgate Hospital. And then the quad blood screen is just the second part of the SIPS for those who are presenting late. So anyone at 14 weeks or over can be offered this test. Results of these blood tests are available 10 days after the final blood work is drawn. And if there's a positive result, the patient will be offered a publicly funded NIPT or referral for genetic counseling. So publicly funded tests continued here, the funded NIPT. So just a reminder of what that is. It's just a blood test that uses cell-free DNA circulating in maternal blood to assess the chance of trisomy 21, 18, and 13 in the pregnancy. It has a higher detection rate, but it still is just a screen. It's not diagnostic. So it will be offered to women funded for those who had a positive screen from the IPS, SIPS, or quad, or who had a previous pregnancy with trisomy 13, 18, or 21. And then anyone 40 or over can be offered CVS or amniocentesis at BC Women's without one of those other prior tests. So private NIPT, it was originally developed to screen for the trisomies 21, 13, and 18. Patients can choose to add on fetal sex at no charge. And then there are some other add-ons. So microdeletion panel and rare autosomal trisomies. These do have a high false positive rate and are not recommended to order. And then patients can also add on sex chromosomal aneuploidy. The timing and cost of the NIPT depends on the vendor that the patient goes for, and there's 2 main options in BC I'll talk about next. This requires a requisition from the provider and a payment form that the patient can access online. High-risk results will require a referral to maternal fetal medicine at BC Women's to discuss further management and diagnostics. So the 2 main options available right now include Harmony through Dine. Their basic panel is about $300. The patient has to do this blood work in the hospital anytime after 10 weeks. And the results are available on an online portal to the patient 24 hours after it's been released to the provider, even if the result is positive. Panorama is through Life Labs. The basic panel is $550 and location is at any Life Labs anytime after 9 weeks. And the results are available on My Care Compass. 5 days after released to the provider. So results in total take up to 14 business days. Patients can access their results, including the fetal sex. A couple other private options are the first trimester screen, which is only available in Vancouver at PCRM Fertility Clinic, and something called Maternity T21 through Dine. I just learned about that during this presentation. It includes microdeletions, and I probably won't be recommending it to my patients, but I don't know too much about it beyond that. Okay, next slide. Just a brief summary comparing the funded SIPs and IPs and then the private NIPT. So the SIPs and IPs, they are free. They're 1 to 2 blood tests. The earliest you get the result is the 15th week. The detection rate for trisomy 21 is fairly good. It's 85 to 90%, with a false positive about 5%. The NIPT is more costly. It is 1 blood test. The result is available a bit earlier at 11 weeks, and the detection rate for trisomy 21 is 99%, and false positive is quite low. So regardless what is chosen, a positive screen will require a discussion with maternal fetal medicine for diagnostic testing, and it is not recommended for people to private pay for the NIPT and also have the publicly funded one, as this increases the chance of having false positives and confusion and anxiety for everyone. So just a quick slide. If anyone's interested in following their patients beyond the first trimester, this is some information you can look at later, and we're always happy to chat and support doctors who would be interested in doing that. And just some takeaways from that part of the section. So dating ultrasound has changed. It's between 11 weeks and 13 weeks and 6 days. A reminder of how to order the urine culture and sensitivity, review about thalassemia screening in high-risk patients, adjustment of levothyroxine, reminder to do a preeclampsia risk assessment in everyone and start aspirin and calcium if they qualify, and then to discuss genetic screening options early with your patient. I would discuss it at the time of diagnosis and then order the test that the patient would like.
Okay, now we're going to talk a little bit about your patient disappeared for the rest of their pregnancy, and now they're coming back to you with a newborn. So just some key things that we tend to see. So in terms of weight gain in the first month, again, it's normal for babies to lose up to about 10% of their birth weight in the first couple of days. Most babies should regain their birth weight by about 10 to 14 days. The Lionsgate Maternity Clinic will follow babies until they have regained their birth weight. So we're not going to discharge you a baby who's significantly below birth weight or below birth weight at all. However, given the capacity issues, we may discharge a baby at 2 weeks who's past their birth weight and doing well. And in this case, they should probably be seen by their family physician about 2 weeks later, around 4 weeks, just to ensure there's continued ongoing appropriate weight gain. And what that is about 20 to 30 grams per day. And often in the early weeks, we find this to be more useful than tracking percentiles. So we just calculate how much they've gained sort of between your 2 visits, divide by the number of days, and you get your grams per day. So 20 to 30, as I said, we don't really get fussed if it's over 30 grams per day, especially in an exclusively breastfed baby, because these babies tend to regulate themselves quite well. So they may gain more than that. And then certainly everyone knows that tracking percentiles in babies is very important. So that probably becomes more important starting around a month. And certainly by 2 months, we want to be trending the percentiles at every visit. A quick note about vitamin D supplementation. We recommend that for all babies, so 400 international unit. It's definitely needed for all breastfed babies, and it is also needed for formula-fed babies until they're getting a liter of formula per day. So formula has some vitamin D, but they wouldn't get enough until they reach that volume. So sometimes people are like, oh, I don't need vitamin D, my baby's getting formula. Most newborns are not taking a liter of formula per day. They may get to that volume as they get up there in age, but right away they should probably all be taking a vitamin D supplement. And then I just wanted to talk a little bit about the period of purple crying, because I think that's something that we see a lot of, and I know family physicians do as well. So it's a normal phase in baby's development in which they get fussy or cry for long periods of time. Usually starts around 2 to 3 weeks of age, peaking around 6 to 8 weeks and resolving by 3 to 5 months of age. So when we hung on to our babies until 4 to 6 weeks at the maternity clinic, we would counsel a lot about this. For the babies that are getting discharged at 2 weeks, often they aren't showing a lot of signs of this, so they'll be followed by their family physicians. And so it's good to know how to approach that. People have called this kind of colic or the witching hour as well. So just a quick graphic about what the letters in purple stand for. So starting around a couple weeks, peaking, as I said, in month 2. It can be unexpected. It can come and go and you don't know why. Sometimes it's quite difficult to soothe. Babies often look like they're in pain, can go on for quite a while, and it's often worse in the afternoon and evening. And this is a graph that I won't go in huge detail about, but the vast majority of babies, so this kind of shows that time period, 2 weeks, peaking at 2 months, resolving by 4 to 5 months. Most babies are going to be lower average criers. So those aren't going to be your colicky babies that are crying for hours and hours and hours on end. And so I think a lot of people think, their baby, parents will describe their baby, instead of crying for hours, they'll say their baby looks gassy or uncomfortable, or it looks like they're trying to pass a bowel movement or pass gas. And I sort of will have a conversation with parents and say, like, okay, so is it the afternoon and evening? And does the baby look uncomfortable and squirmy and kind of fussy and a bit difficult to settle, but not like crying and crying necessarily? And then I eventually, you feed the baby, or the baby passes gas or has a bowel movement, and all of a sudden it's settled and the night is fine and the morning is fine, and then come afternoon or evening, it starts all again. Parents will often be looking for solutions to, is it gas? Is it something in their diet? And when it follows that pattern, usually we can just say, this is just purple crying. This will pass. So what to do about it? Obviously, counsel parents to check to make sure the baby's basic needs are met. Are they fed, changed, not too hot, not too cold? Really offering comfort measures is the biggest thing. So walking, shushing, rocking, skin to skin, offering a pacifier, breastfeeding, try to figure out what's going to work for your baby. And sometimes comfort measures are needed for parents as well, which I'm sure many of you know. If you've had children, fussy baby is unpleasant. So, if your baby is crying a lot, put on some noise reducing headphones, take a break. It's okay to leave the baby for a little bit, just to make sure you don't become overwhelmed with it. What doesn't work? There's really very limited evidence for oval gripe water. Having said that, there's no real harm with that either, but it's not likely to be effective. In most cases, dietary changes are not going to be effective unless you think there's like a milk protein allergy suspected. Acupuncture, chiro, osteopathy, craniosacral therapy, massage therapy, none of these have any evidence. And in fact, some of them can be quite harmful. So I would advise against that. And again, in terms of treatment of reflux, there's really minimal evidence for benefit with like medication treatments for this, even in babies that spit up, that it's going to have much impact in terms of the period of purple crying. So the biggest thing is to make sure we do appropriately rule out an underlying medical issue. Is the baby gaining weight appropriately? Is there bloody stools? Does the baby having an episode of crying? Do they have a hair tourniquet somewhere? And once you've ruled those sort of worrying causes out, the biggest thing is reassurance that this will pass and that it's normal and they don't need to do, extensive dietary modifications or medications or anything like that. A quick note about reflux in babies. Reflux in healthy term infants, reflux symptoms are very nonspecific, and they do overlap with these normal age appropriate behaviors, purple crying that I've been talking about, and that spitting up is incredibly common. 20% of babies at a month, up to about 40% of babies at 3 to 4 months, and then it should decrease by a year. Avoiding cow's milk does not treat GERD unless there's a subset of babies, who may have a cow's milk protein allergy. And often with that, you may be seeing bloody stool, that sort of thing. They may benefit from a 2-week trial of cow's milk protein removal and then continued breastfeeding, but we would expect those symptoms to improve quite quickly. So if they haven't improved after 2 to 3 weeks of a cow's milk protein out of mom's diet, I would usually just reintroduce it and stay the course. And as I said, there's really minimal evidence to support treating reflux in the vast majority of babies. A quick note about breastfeeding, which I know can feel overwhelming. The most basic physiology that I sort of teach all parents who are with us is the more milk you take out of a breast, the more milk you're going to make. And another way of saying that is empty breasts send the message sort of to the brain to make more milk. Full breasts are going to send the message to make less milk. And if you approach many of your supply breastfeeding problems with this basic physiology in mind, it becomes a little bit more approachable. So some basic breastfeeding troubleshooting that you may need to do with patients in your office. If someone reports their supply is dropping, we really want to ensure the breasts are being emptied. So either the baby is feeding directly at the breast or that you're pumping at least 8 times per day. And I think a lot of people will report a bit of a dip in supply when babies are 2, 3, 4 months old, and they start to sleep those longer stretches at night. Many women, their breasts can't sort of handle that, the breast being full without their supply dropping. And so we do see a lot of supply dropping at that point, in which case, it's a conversation about waking up at night to pump the breast or to pump before you go to bed, or adding supplementation, although obviously we want to support breastfeeding as best we can. Again, in that circumstance, if supply is starting to drop around 2, 3 months, domperidone is rarely necessary. There are some updated guidelines from Women's that I'm not going to bore you all with, but essentially most patients don't require domperidone. Usually we can improve the supply with increasing the frequency of emptying of the breasts. If you are considering domperidone, all patients should have an ECG prior to starting. And at that point, probably worthwhile to be referring your patient to a lactation consultant just to get some additional support. And then a final note about the domperidone is there's been increasing reports of a potential impact on mental health, especially while discontinuing it. So it is something to be aware of your patient is on, to sort of have that conversation with them ahead of time, and then to screen them closely during that period. Other things that patients will often report is one breast makes more than the other. You can just reassure them that that's generally normal. And if patients are struggling with the latch, often they'll report pain. Honestly, the best thing to do is probably to refer them to see a lactation consultant to get some support with that. And there are both private and public options on the North Shore. So that's the public option is achieved through a referral through public health, and patients can self-refer or can reach out to the public health nurses who would have been in touch with them in the postpartum period. But the answer is not Dr. Jack Newman's all-purpose nipple ointment. So the evidence for that, there is none. It's kind of overkill with antifungal, antibacterial, steroids. So that's why I would encourage reaching out to a lactation consultant rather than just prescribing the nipple ointment. In terms of blocked ducts and mastitis, there were some updated guidelines in 2022, which basically are quite a stark difference from what we previously recommended for blocked ducts and mastitis. And the first thing of note is that not all lumps in breastfeeding women are in fact blocked ducts. So, if the story fits and you think it's a blocked duct, obviously go that route. But if it's not responding quickly and in the way you would expect, to make sure you investigate for breast cancer as you would if not breastfeeding. And it is okay to get mammograms and ultrasounds while breastfeeding. So what do we recommend now if you're experiencing blocked ducts or potentially early mastitis? Instead of aggressive massage to clear the blockage, we're recommending lymphatic massage. I have a slide on that next just to demonstrate it, but there are some videos online that patients can access. We used to say, pump, feed on the affected side more, that tends to contribute to oversupply or milk overproduction, which causes inflammation and swelling. So instead, we would say avoid pumping, just try to feed on demand from the breast. Tylenol and Advil are going to be helpful for you. Ice or heat, whatever is most comfortable for the patient. And there's a supplement, lecithin, which has some evidence for treatment as well as prevention of blocked ducts. So if someone's getting lots of blocked ducts, that may be a worthwhile supplement to look at. And certainly do not unroof blebs, and not everybody needs antibiotics for blocked ducts or mastitis. So just a little slide about lymphatic massage. Again, so basically it's really gentle movement kind of from the nipple upwards to try to drain the excess swelling. And then in terms of mastitis, who does need antibiotics? The vast majority of cases of mastitis are inflammatory and thus not infectious, and so don't need immediate use of antibiotics. So the conservative measures that I just mentioned, they need time to work, 1 to 2 days at least. And then you can consider use of antibiotics if a fever is lasting more than 24 to 36 hours and not responding to conservative measures. I did just link to the iAble breastfeeding handouts. That's a wonderful resource, very evidence-based for a variety of breastfeeding challenges. And they have a really nice handout for blocked ducts and mastitis. So whenever somebody has that, I always just print it off and give it to them. So that might be worth looking at if you ever encounter that. And then we're going to talk briefly about mom's health. So in terms of postpartum mental health, I think everyone knows postpartum depression and postpartum anxiety are both very common. I think we're seeing increasing rates of postpartum anxiety in particular. So, about 10 to 15% of people will experience postpartum depression, and up to 20% with postpartum anxiety. So everyone should be screened with the EPDS, the Edinburgh Postnatal Depression Score, at around 6 to 8 weeks. And I know that the OBs do that at discharge, as does the Lionsgate Maternity Clinic. But preferably at all visits in the postpartum year, or at least a couple of visits throughout the postpartum year, just to catch anyone who may not have been picked up in that early screen. A score of less than 8 is low risk. You can kind of just rescreen as needed. A score of greater than 12 suggests a really high possibility of depression or anxiety. And we should really be putting supports and additional resources in for these patients. And kind of 9 to 11 is a bit equivocal. So I would watch someone with a score like that quite closely, rescreen in a couple of weeks. And these are often quite under-recognized by healthcare providers. There's certainly stigma associated with disclosing symptoms of anxiety and depression, and it's especially true in Indigenous peoples due to racism and discrimination in the healthcare system. So just having a really, looking carefully for this in a lot of our patients so that they don't fly under the radar. I just want to talk briefly about postpartum anxiety, because I think it's often underdiagnosed compared to postpartum depression. I think a lot of people will come in and say, "Oh, I'm just a first-time mom." And while they may present with the typical symptoms of anxiety that all of you family physicians are aware of, there are some specific postpartum specific ones that might not clue you into this being postpartum anxiety. But intrusive thoughts are quite common. And so these are recurring thoughts or images of harm happening to the baby. And they can be quite uncomfortable for patients, and they're very common. Or people having unrealistic or excessive worry about the baby or other topics. Excessive checking or looking for reassurance in terms of sort of online research, or even, the parent who's bringing their baby in frequently just looking for reassurance for what seem like fairly minor things to us. Often those are patients who, when you actually stop to ask them, how are they doing, they'll start to disclose that there is significant anxiety going on. Patients may avoid people, places, things, or they can be quite rigid in terms of schedules, not wanting to be alone with the baby, or not being able to leave their baby with others. So if you have someone that you're concerned about from a depression or anxiety perspective, this is common family doctor stuff, obviously do a safety and risk assessment, looking for suicidal and infanticidal thoughts or ideation. And it is really important to differentiate that from those intrusive thoughts that I mentioned before. The difference being the intrusive thoughts are quite distressing to patients, but they often don't want to disclose them to you because they're worried. They're like, oh, I'm a bad mom, or they think I want to hurt my baby. But these are thoughts that they can't control of, bad things happening to their baby. And so it's important to kind of try to tease out the difference between the two in a really non-judgmental way. And then it is important as well to screen for postpartum psychosis and bipolar disorder, as this often can present for the first time in the postpartum period. Sleep deprivation, hormone changes can really trigger that. If there's urgent safety concerns, obviously your patient needs to be sent to the emergency department, or we've had some success speaking with the psychiatrist on call as well. If you have no acute safety concerns and it's just something you think we have time to address, NESTS is a really useful framework for sort of in-office brief CBT and counseling, and I'm going to chat about that shortly. And then obviously you can refer your patient for CBT or private counseling. Medications often will play a role, and they're certainly safe to initiate in breastfeeding. SSRIs, especially sertraline, has the most safety data. And then if the future pregnancy is planned, that's a good option, but the other SSRIs are acceptable as well. And sleeping aids can be very helpful as well, like lorazepam or quetiapine are okay even in patients who are breastfeeding. And so that's something to consider for patients who need to get some sleep. There are supports available. The Pacific Postpartum Support Society, patients can self-refer to. The St. Paul's Reproductive Mental Health Program is excellent. And then if anyone ends up getting these slides, this is a link to an at-home self-management program guide, so very CBT based, that patients can access on their own. In terms of NESTS, as I mentioned, that's a framework for some kind of brief in-office CBT that you can do quite easily, or you can kind of review on your history with patients. I bolded sleep because that one probably is the most important, but in terms of the N, nutritious, just making sure people are getting, nutritious food, water throughout the day. And that's a place where you can get support people involved, just bringing food, bringing them water, that kind of stuff. Exercise, we all know small amounts of exercise can help boost mood and energy and decrease stress and help promote sleep. So getting out for even just short little walks or a little bit of exercise can make a big difference. In terms of sleep, I think we all know that sleep deprivation can really impact mental health. If there are significant concerns with mood or anxiety, I would counsel your patients to aim to get 2 stretches throughout the week, or 2 to 3 nights a week of getting 5 hours of sort of uninterrupted sleep. And that may mean mom needs to sort of hand off the baby to someone else for the night and give formula or prompt breast milk. And that may impact breastfeeding, but long run, that's probably going to help with mood and anxiety. And again, for the person who is just lying there and they're so anxious that they can't sleep, the use of a sleep aid can be very helpful. And then once people have started to get a little bit of sleep, we often see improvement in the anxiety and depression. It's really important to counsel parents to get time for themselves. And that can feel really overwhelming and daunting. But even just a few minutes, a walk around the block to do something that they enjoyed before they had the baby, or, that brings them a little bit of a break because it's a very 24/7 job, and that can be overwhelming, especially if you're struggling with anxiety and depression. And then finally, support. Just encourage people to ask for help. It takes a village. And, family and friends are usually more than happy to offer that support. Almost done here. So I was just going to chat quickly a little bit about pregnancy and cardiovascular risk. So a history of preeclampsia is a risk factor for future cardiovascular risk. So, 20 years down the road, when women are presenting with chest pain or cardiac symptoms, go back, ask them about their pregnancy history, and if they had a history of preeclampsia, especially severe preeclampsia, consider that patient a little bit higher risk for cardiac events, and make sure to address that appropriately. And then if your patient comes back from us at the maternity clinic and they reported that they had a history of preeclampsia, we would recommend doing sort of screening lipids when done breastfeeding. I'm not actually sure if breastfeeding impacts lipids all that much, but that's the recommendation. And then aggressive risk factor modification in the future just to prevent that. And I think everyone knows what that is. They should certainly be counseled about aspirin in future pregnancies. And periodic blood pressure checks. And it's probably worthwhile to sort of mark on the chart for those types of people, history of preeclampsia, and that'll trigger you 20 years down the road to think more about them. And then in any patients who had gestational diabetes, it is recommended to rescreen them between 6 weeks and 6 months postpartum with a 75-hour glucose tolerance or 75-gram glucose tolerance test, just to see if we can diagnose anyone with impaired fasting glucose or increased risk of diabetes. Key takeaway points. Dr. Masick-Neumeier kind of did hers already. In terms of my key takeaway points, all babies cry. Reassurance is most often all that is required. Make sure to screen for postpartum depression and anxiety and get comfortable using nests as a framework for kind of that in-office counseling. And I would, as I said, recommend making a note in your chart if your patients had more complex pregnancy histories, because it can be useful in the future. Now we will open it up for questions.